So, can you all hear me?
Yes.
Good. Thank you very much, Dr. Shokan, and all the organizers for giving me this opportunity. This is a very interesting topic. As Dr. Ashokan pointed out, often when we started our practice, we were doing room air ventilation, but we went with a guilty feeling that we were doing the wrong thing. And then we were in search of oxygen. And finally, after some years, suddenly people told us, actually, you should be doing room air ventilation. It is very nice to have a topic which, which is interesting from many points of view. One of it is, of course, the fact that we were in the change-making era when we have shifted from oxygen to room air. So in this 20 minutes, I am planning to sell the idea of room air ventilation. I'm going to be a marketing salesperson. If at all you have not yet changed over, I'm hoping that you will get convinced. And at the end of this talk, you're going to go back and say, you know what, I'm not going to use oxygen. First of all, I'm going to just give you a brief introduction. Then we will talk about how did this oxygen for resuscitation come into practice. Then we will talk about who gave the idea that we should be using lower oxygen concentration at all. And once somebody gives an idea, this is a very beautiful way how that idea was first tried out in animals. And then they thought of all the side effects of oxygen on lung and its injury. And then they started the trial in newborns. And finally, the recommendation came. And recommendation took a long time. So it is a very interesting phenomenon and it's a good history for us to learn. One other reason why I like this is the fact that one of the events for which India can stand up and say proudly say we were one of the reasons for doing it is our own Professor Ramji was one of the people who pioneered this concept way before the rest of the world took it up. And we can proudly say this was an India thing that we did. So it is, when I look at this question, I am used to resuscitation with oxygen for the last 30 years. So why should I change practice? Like when in 2013, somebody said, why don't you use a smartphone? And I said, I don't need a smartphone. So I can't live without a smartphone. I was taught to use oxygen for resuscitation. A changing practice. I have not seen any harm, so why should I change now? And the third, probably these studies were done in the Western world and with oximeters. That is not practical in the day-to-day life at all. And then the last thing is, this is probably for preterm babies and ROP, and the brief resuscitation is not going to really harm. Now, these are all myths. And I think this is the time we can look at it and say, no, we need to change. So, starting off, you know that 5 to 10% of babies are asphyxiated, 25% of them die, 25 have sequelae. And do you know that before 2010, most international consensus recommended 100% oxygen-based, not on evidence, but purely because that was a practice in the past. It is one of those questions that has always been done. Why did you do it? Because that is how we are learned. The first doubts was on the plant, the seed was sowed in 1966 by one Dr. Campbell. As I said, this is going to be a small history lesson also along the way. Here he compared air and hyperbaric oxygen in newborn rabbits. And he found that neither the time of first breath nor the survival was different. So that's how it first started. Now we have to thank this guy, this researcher called Soxter, who really took it as his passion for the next 25 years. And this was his work. In the 1980s, he suggested that oxygen is bad in post-asphyxial period. And as you all know, there is oxygen-free radicals. And also he showed that the cerebral blood flow in term and preterm babies were actually slowed down. So he started questioning, should we be using oxygen at all? This is 1980s I'm talking about now. So from 1966, it's already 15, 20 years gone. And he gave the hypothesis that 21% oxygen is as effective as 100% oxygen. They had to do some studies to do it before you move it into human beings. And they did these studies on piglets. This was published in the 90s and showed that there is no difference in the outcomes as far as blood pressure, heart rate, acid-base balance, hypoxanthine levels, cerebral blood flow, and including neuropathological examination. They found there is no difference at all. So this was the early 90s. This was the thing that was in the literature at that time. Recently, they have found actually there are better outcomes, but this was not known at that time. They thought it's going to be as good as, not better than. Then people started questioning, if I change for routine resuscitation, what about meconic aspiration? You're going to have children with meconic aspiration, and you know that for pulmonary hypertension, oxygen is needed. And that they tried to do another animal model where they had asphyxiated piglets and they poured meconomin through those and then saw there was no difference at all. In fact, they said the achieving adequate tidal volume is more important. And they said there's no difference. Then the question started coming up, is oxygen, so they first proved that air is as good as oxygen. Now the question came is oxygen causing damage? And they looked at prolonged 100% oxygen use produced lung fibrosis. I think that is not the current problem that's happening in COVID therapy now. People are having pulmonary fibrosis after having extensive use of oxygen. Then the question came, any brief exposure, is there any effect? So you found that 3 studies recently coming out in 2009, 13, and 17 have showed an increased BPD with hyperoxemic resuscitation. But this is not conclusively proved because there are other studies which say there's no difference. Other than lung, is there any other organ damage? They initially found there was no neuropathological damage in the early studies. But in 2004, articles started coming out that actually there is damage to both the myocardium and brain when 100% oxygen is used. So this is the background to which we are working. So the first time in 1993, Professor Ramji and the same Norwegian guy called Sogstedt decided that they will do a pilot study of 84 cases. And this was the first trial done in the world. This was followed by a multi-centric trial in India, Egypt, Spain, Estonia, Philippines, and Norway. Honestly, I don't know where Estonia is. And they looked at 600 cases. Then simultaneously, somehow US never got into this argument. Spain decided to check it out, and he did for 2 studies, one in 538 and another 100 cases. And then Ramji did one more study in India, a multicentric trial of 418 cases. Totally, they have 881 cases with room air and 856 cases with 100% oxygen. And they came to the conclusion, you can resuscitate with room air. And that was the final conclusion they could do. Just looking at briefly on these studies. In the pilot study, they used the inclusion criteria of heart rate less than 80 and birth rate more than 1,000. And we're looking at UPGARs. As Sindhil pointed out earlier, UPGAR at 5 minutes actually shows the effectiveness of resuscitation. In the multicentric trial, again, they were looking at mortality and HI. In the Spain trial, they were looking at mortality again at UPGAR at 1 and 5 minutes. And the Indian multicentric trial is again UPGAR at 5 minutes. All these studies were done. You have got these 1,700 children allocated between these 2, and these are all quasi-randomized trials. 3 meta-analyses came out in 2004. One obviously was done by Ramji and Southstead himself. And meta-analysis is that you are putting all the data together and trying to come to a conclusion. And they came to the conclusion that not only is it as good, in fact, it is better. They found that the first breath and cry was significantly delayed by 1.5 minutes if 100% oxygen was used. And if the duration of resuscitation was significantly prolonged by 2 minutes if 100% oxygen was used. The 5-minute UPGAR was significantly higher in the room air group and no significant difference in failure of resuscitation between the 2 groups. This was very important. So, going over it again, 881 patients with 21% oxygen and 856 100% oxygen, 5 studies, 2 from Spain only used term babies. And the mean birth weights were around 2,400 to 3,300, gestational age 37 to 40 weeks, and the mean UPGAR at 1 minute were 3 and 4. These was a group that they were actually concentrating on. They found 69 deaths in the room air group and 111 deaths in the 100% oxygen group, effectively 8% and 13%. Clearly, there is a difference. Then some said, you know what, all these studies are primarily in India, because they're talking about India, Egypt, Estonia, which I assume is probably somewhere in Europe, probably in Eastern Europe, and then Philippines. So they said, why don't we look at Spain? Because that is a Western country. And there they found that if you use room air, the death was only 0.5%. If you use oxygen, it is around 3.5%. Then what if it was term and preterm? Probably there's no difference. And again, they found if you have 100% oxygen in a term, 9.5% mortality, while if you use air, it is 5.8% mortality. Even if you use preterms, it is 35% mortality with 100% oxygen and 21% if it is air. If the upcar was less than 4, at 1 minute, there are no much difference between these two. So they started looking at the neurological outcomes. They've done evidence of upgas and resuscitation effectiveness. Now, what happens is HIE in 3 trials, they found no significant difference in grade 2 and grade 3 encephalopathy. Only one trial of the 600 infants that was done in India with the multicentric trial did a long-term follow-up at 18 to 24 months, and results were published in 2003. Only less than 70% follow-up, that was probably the weakness in the study, and they found the somatic growth and developmental milestones similar. Further studies. So by 2004, you had so many trials and meta-analysis, but the ILCOR guidelines still recommended 100% oxygen. So 2 more studies were done in Spain and India, and the numbers started going up. You had 2,011 newborns by 2007 and 2,133 newborns by 2008. And in everything, it consistently kept saying that room air is better, room air is better. And finally, it was time for change. In 2010, the ILCOR guidelines recommended use of 21% rather than 100% for resuscitation of term babies. This is why when I did my MD pediatrics from 1990 to 94, and what I now teach are totally different, because time has moved on, and as you can see, the guidelines have also changed. In 2015, hardly any new studies, so they said the same recommendation, and now we are using pulse oximetry also. So there's one more meta-analysis published in December 2018. And in that, it's clear there are no more new studies. In fact, they tried a new multicentric randomized control trial in 2012, but they had to give up because they could not recruit any more patients, because the world had moved on. So in the meta-analysis in 2018, it again shows that statistically significant reduction in short-term mortality by using 21% for initial resuscitation for term and late preterm more than 35 weeks. And no statistically significant difference in short and long-term neurological outcomes. Just a brief idea about oxygen. See, one of the problems is that even as I practice neonatology and I teach neonatology, even if the baby is not breathing, people tend to just start oxygen. Baby is apneic, start oxygen. Baby has respiratory distress, start oxygen. We are not looking at saturations. We are not looking at other aspects of ventilation. We are not looking at oxygen delivery. Therefore, it's very important to understand that just increasing the FiO2 is not the answer to the problem. And that is why sometimes we are falsely looking at oxygen as a panacea for resuscitation. Oxygenation is actually the process by which oxygen diffuses passively across the alveolus to the capillaries, while if your rate of oxygen delivery from the lung to the peripheral tissue is actually called oxygen delivery. And oxygen consumption is the rate which oxygen is removed from the blood by peripheral tissues. If you want to have a good oxygen delivery, depends on the fraction of oxygen that you inspire, but also depends on adequate ventilation, adequate pulmonary blood flow, adequate cardiac output, hemoglobin, and local tissue factors. That is why when we teach an NRP, we talk about good resuscitation with good chest movement, cardiac output should improve. All these are a baby with anemic and hydrops will not improve by just giving oxygen. Measurement of oxygen delivery by pulse oximetry, it is important, and I'm not sure how many of us really practice it, but that is what we really need to do, because too much and too little of oxygen is not good. 2017, they tried to do the resuscitation for babies less than 28 weeks, because these recommendations are a bit of iffy when it's below 28 weeks, because NRP clearly says that if it's below, for preterm babies, you can start some amount of oxygen. So people are trying to see whether you should start 30 or less, or you start 60. And they've actually found no difference in clinical outcomes, whether you are talking starting at 30 or 60, no difference in mortality, no difference in BPD, no difference in IVH. But they found if you use room air, you had less respiratory support and less PD. So I'll be probably finishing a couple of minutes early. I'm sure the organizers will be happy. In summary, initiate resuscitation with 21% oxygen for 35 weeks and over. Titrate by achieving pre-ductal saturation using the NRP oxygen guidelines. If your heart rate continues to be slow and you're having problems with resuscitation, then start using a lower percentage of oxygen and try to titrate it. But if you still continue to have a problem at 90 seconds and the baby is not recovering, then obviously you are going to use 100% oxygen. And if you're going to use chest compressions, then you're going to use 100% oxygen. Between 21 to 31%, 30% of oxygen you use for preterm less than 35 weeks. And again, titrate to maintain oxygen saturation targets. Remember, it is not oxygen alone. You have to look at ventilation. You have to look at giving adequate tidal volumes. So looking at chest movements, cardiac output, looking at good heart rate, volume, and adrenaline. I hope that I have been able to convince you historically and also with a sense of nationalistic pride that we should be using room air for resuscitation, and oxygen is not that good a thing as we thought it was.
Thank you very much, Dr. Binu Ninan, for a very clear and lucid presentation. And I hope and believe, and there will be a practice change among the audience. And